Welcome to The Explainer. Today we're going to tackle a really tough diagnosis, one that's super important to get right: advanced heart failure. We're going to talk about how you, as a trainee, can move past just thinking of someone as a sick heart failure patient and get to a really precise diagnosis. Because, getting this right opens up a whole new world of treatment options for them. So let's break it all down: how to spot it, how to work it up, and how to nail that diagnosis with confidence.
Okay, so first things first, let's get grounded with the official definition. And I want you to really zero in on one key phrase here: despite maximum tolerated evidence-based therapy. That right there is the whole game. See, we're not just talking about someone with bad symptoms. We're talking about a patient whose heart is still failing, even when we're throwing everything we've got at it, our entire medical playbook. It's just not responding. So, okay, a definition is great for a textbook, right? But what does this patient actually look like, when they're sitting in front of you in clinic or when you pick them up on the wards? That's the real skill we're talking about. What are those little clues, or maybe not so subtle signs, that should set off alarm bells in your head and make you think, could this be advanced heart failure? So to get us there, here's the game plan. We'll nail down the definition, paint the clinical picture, walk through the workup, talk about confirming the diagnosis, and then, super important, we'll ask, what else could this be? Okay, so let's really dig into this first part, defining the condition. Now, you're going to hear people throw around the term end stage, but think about it. That sounds so final, almost hopeless. And that's why our source material really pushes us to say advanced heart failure, because it's not an endpoint. It's a working diagnosis. It's a trigger that tells you, okay, time to shift gears, time to think about a whole different set of therapies. And that is a huge mental shift for a clinician to make.
Right, so let's be super clear on this. This is not about a patient who's undertreated. Not at all. This is the patient who is on the whole shebang: the beta blocker, the ACE inhibitor, the MRA, the SGLT2 inhibitor. They're on everything they're supposed to be on, at the highest doses they can handle, and they're still struggling, big time. That resistance, that failure to respond to our very best therapies, that is the absolute heart of this diagnosis.
Okay, so how do we actually spot this patient in the wild? Let's start building that clinical profile. What are the things you need to have on your radar? This is how we move from just a gut feeling to a really structured way of thinking about it.
And to help us get our heads around this, the source material gives us this awesome mnemonic, and you're not going to forget this one because it's literally what the patient's body is screaming at us: I need help.
Okay, this I need help mnemonic is just fantastic. Let's run through it piece by piece. So I is for inotropes. Is your patient dependent on IV drugs like milrinone just to keep their organs perfused? That's a huge red flag. N is for NYH class 3 or IV symptoms. We're talking about someone who gets short of breath just walking to the bathroom. The first E stands for end organ dysfunction. Are their kidneys taking a hit? Is their creatinine climbing? That tells you the engine isn't pumping enough fuel to the rest of the body. The second E is for a really low ejection fraction. We're talking less than 20%. D, defibrillator shocks. Has their device gone off? That means their heart is electrically unstable. It's a very bad sign. H stands for hospitalizations. The revolving door patient. More than one admission for heart failure in a year is a big one. The next E is for edema that just won't go away, even as you're cranking up the diuretics. L is for low blood pressure. The pump is just too weak to maintain a systolic pressure over 100. And finally, P, and this is a tough one, prognostic medication intolerance. This is when you want to put them on those life-saving meds, but you can't because their blood pressure just bottoms out. Even seeing one or two of these should make you pause. But when you start seeing a bunch of them together, that's a really, really strong signal that you're dealing with advanced heart failure. All right, so the I need help mnemonic has your alarm bells ringing. Your clinical suspicion is way up. Now you've got to back that up with some cold, hard data. So what's the workup look like? Let's dive into the evidence gathering. So we're going to follow a really logical path here, moving from the simple stuff to the more complex, invasive tests. First, we start right at the bedside, good old-fashioned history and physical. Then we add a layer of initial tests, labs and ECG. Easy stuff. After that, we bring in the big gun of imaging, the echocardiogram. This is absolutely key. Then we have to figure out objectively how limited they really are. So that means some kind of functional assessment. And then for the patients who might be candidates for the really advanced stuff, we get the definitive numbers with a right heart cath. Okay, so when you get that first set of labs back, what are you looking for? What story are they trying to tell you? Well, first, look at the kidneys. If that creatinine is creeping up, that's classic cardiorenal syndrome. How about the sodium? If it's low, hyponatremia, that's a sign that all the body's neurohormonal stress systems are just firing on all cylinders. Low albumin, that tells you the patient is in a catabolic state, kind of wasting away. And if you see that bilirubin climbing, that's a huge clue for congestive hepatopathy. Basically, the liver is getting backed up with pressure from the failing right side of the heart. So you see, these aren't just random numbers on a page. Each one is a really powerful clue about how sick this patient is. All right, so we've got our labs. Now it's time to actually look at the heart. And your number one tool for this, hands down, is the echo. It is the absolute cornerstone of this entire workup. Now, when that echo report hits your inbox, I know what you're going to do. We all do it. You scroll right down to the LVF, the ejection fraction. And look, a number under 30% is a big deal, for sure. But you absolutely cannot stop there. You've got to read the whole report. You need to ask, how's the right ventricle holding up? Because a failing RV is a terrible prognostic sign. Is there severe valve disease that a surgeon can't fix? What are the filling pressures like? All of that diastolic information is critical. It's all about getting a complete 360-degree view of how that heart is functioning or not functioning. Okay, so let's recap. We have the patient's story, we have their labs, we have a picture of their heart. But here's the next question. What does that all mean for their day-to-day life? How much can they actually do? Because, a patient might just tell you, oh, I'm doing okay. But we need to get past that. We need objective numbers to really see how limited they are. And that's where functional testing comes in. All right, now for maybe the most important part. We have to put all of these pieces together. This diagnosis is never, ever about one single number or one test result. It's about being a clinical detective, right? You're taking the history, the exam, the labs, the echo, and you're weaving it all together into one coherent story. This is where the art of medicine really shines. And the source material gives us a really solid way to think about this. It's built on two pillars. Pillar number one is your clinical evaluation. You need to see those severe ongoing symptoms, the NYHA class 3 or IV stuff, and you need to see episodes where they just can't keep up, like fluid overload that's really tough to get rid of. Then you have pillar number two, objective testing. This is where you need the hard data. You need proof of severe cardiac dysfunction, like that low EF, and you need proof of severe exercise limitation from one of those functional tests. And you can't have one without the other. You need both of these pillars standing strong to make the diagnosis. So what kind of objective numbers are we talking about? Well, a really simple one that you can do just about anywhere is the 6-minute walk test. And there's a key number you got to burn into your brain, 300 meters. Think about that. If your patient can't even walk the length of 3 football fields in 6 minutes, that is a huge marker of severe impairment, and it's directly tied to a much, much worse prognosis. Now, if you want the gold standard, the most objective measure we have, that's the cardiopulmonary exercise test, or CPET, and that gives us a peak VO2. And just like the 300 meters, there's another magic number here, 12. A peak VO2 of 12 or less, that is a critical line in the sand. When you see that number, it should immediately make you think about referring for advanced therapies. We're talking heart transplant or an LVAD. Okay, so at this point, you've built a really strong case. The story fits, the numbers all line up, everything points to advanced heart failure. But wait, before you finalize that diagnosis, before you put that label on the chart, the best clinicians, the really great ones, they always take a breath and they ask one final critical question. What else could this be? What might I have missed? And listen, this is not just some intellectual game. Getting this part wrong has massive consequences for the patient. Imagine missing something reversible. You could be sending a patient down the road to a transplant or mechanical heart pump when maybe all they needed was their thyroid treated or a CPAP machine. This is an absolutely high-stakes moment. So here's your final safety checklist. 3 things to run through. Number 1, inadequate therapy. Are you absolutely positive this patient is on the max tolerated doses of everything? Or is there still room to push the meds a bit more? Number 2, reversible causes. Have you done your due diligence? Did you check for severe anemia? Thyroid problems? What about untreated sleep apnea? These are all famous heart failure mimics or contributors. And number 3, other conditions. Could something else be the main problem? Is it really their heart? Or is it their severe lung disease or their kidney failure that's causing most of their symptoms? And really, this brings us to the ultimate takeaway. This diagnosis, in the end, is an act of clinical judgment. It's not a checkbox. It's not an algorithm you can just plug numbers into. It's the art of being a doctor, taking all these different data points and synthesizing them, weaving them into a complete and coherent story for your patient. So, I'll leave you with the question to think about. The next time you're on call or in clinic and you see that patient whose heart failure is just getting worse, how is this framework going to change what you do? Are you going to consciously run through that I need help mnemonic? Are you going to think in terms of those two pillars, the clinical and the objective? Because doing that, it's the difference between just chasing symptoms and making a precise, powerful diagnosis that could literally change the entire course of your patient's life.